Good evening, everybody. Welcome to the Wednesday evening webinar. And this evening, we have an update on chronic illness with an overview of chronic illness, but a particular reference to diabetes. And I'm very grateful to Professor Sean Dinneen, who has put together this webinar together with Diarmuid Smith and Delia Bogdanet, who is a specialist registrar, I think, who is doing her PhD. And we were just talking before we went live about the challenges that we face as surgeons now. And for the most part, it's not diagnosis. We have really imaging that was unimaginable when I was a registrar and young consultant. And we have facilities that were simply not available for us, and techniques. So it's not the diagnosis, and indeed, it's not the surgical treatment that's the challenge. The biggest challenge, certainly in my view, is the frailty and the chronic illness that we face in a considerable proportion of the patients that we have to treat. And indeed, in my professional lifetime, the life expectancy of Irish patients has increased by 8 or 9 years. And that hasn't been 8 or 9 years generally of good health. It's been often 8 or 9 years of chronic illness. And so it really is quite a challenge to us. I also have the temerity of mentioning old-fashioned concepts like sliding scale insulin, which drew wry smiles from my colleagues, as you'll see on the screen. So I think all of us who deal with the frailty and the medical complications of our surgical patients, we need to be updated on these things, and I'm very grateful to our three speakers. The rules of engagement are as usual. If you're not speaking, please turn off your camera. And if you're not speaking, also please turn off your microphone. Please use the chat function if you want to put a question, and we'll have a discussion at the end, and we'll try and finish close to 7 o'clock. So, Sean, thank you again, and I'll leave it over to you.
Great. Thanks very much, President, and thanks to Catherine and Paula for helping us get organised for the webinar. So my name is Sean Dinneen. I'm an endocrinologist based in Galway, and along with my colleagues Diarmuid Smith and Delia Bogdanet, we're going to take you through three approximately 15-minute presentations covering diabetes care in the COVID-19 era, which is myself to lead out, followed by Diarmuid, who will speak about issues relating to type 1 diabetes in the hospital setting, and then Delia will cover issues relating to type 2 diabetes. So hopefully it will be useful for you, and we're certainly very glad of the opportunity to present this update. The next slide is a slide that I used back early on in the pandemic when I was asked to speak to RCPI as opposed to SI about diabetes in COVID-19. This slide you'll see is dated April 2020, when we were all fretting and looking down the barrel of Bergamo and things like that. And at that time, what we understood from Wuhan and places in China was that people with diabetes were not necessarily predisposed to developing COVID, but they were certainly at increased risk of a more severe outcome from COVID-19 infection. That's true for other chronic diseases as well, and for people who are immunosuppressed or immunocompromised. Next slide. So about 2 years on, our knowledge hasn't really progressed a huge amount. We still know that people with diabetes, particularly if it's poorly controlled, have worse outcomes. And trying to parse that out, and this recent paper in Diabetes Care speaks about COVID-19 induced diabetes, which is a phenomenon that we have recognized, partly perhaps related to the use of steroids, particularly dexamethasone, when people develop oxygen requirements Some people will have pre-existing unrecognized diabetes that becomes recognized during their COVID-19 illness. And then there's this phenomenon of stress hyperglycemia, which is seen in other infections, not just in COVID. But the intriguing thing, I guess, from the biology standpoint is whether the SARS-CoV-2 virus actually damages pancreatic islet cells or beta cells. And I think that's still not certain, but there's certainly work going on. Next slide. And this next slide speaks to this kind of complicated kind of bidirectional relationship between diabetes, especially with poor glycemic control, either pre-existing or new onset, but certainly when blood sugars are not well controlled. This idea of compounding the COVID-19 infection, again, almost certainly, interacting with the cytokine storm, the stress response, perhaps beta cell damage, as I've mentioned, and ultimately leading to poor outcomes, with ketoacidosis and hyperglycemia. Next slide. So that's really, I suppose, the biology part of my contribution. I'm national lead for our diabetes clinical program, and I'm going to speak for the rest of my time on the impact of COVID and the pandemic on diabetes services and on the delivery of chronic disease care. And I'm going to try and put a positive spin on this, because if I'm honest, and if we reflect on the past 2 years, it hasn't been all bad from the standpoint of our health service, recognizing that really the two main challenges, as the president alluded to in his introduction, are our aging population and chronic disease. So they are really where it's at. And as surgeons or as any discipline, you will be seeing more and more diabetes coming into your hospitals and into any part of the hospital. So I'm going to touch on issues relating to our embracing telemedicine and delivering virtual as opposed to face-to-face clinics. I'm going to talk about the challenges associated with self-management education, getting people with diabetes to become skilled in self-management, a key element of the whole thing. I'm going to compare and contrast the approach in Ireland to retina screening and foot services. I'm going to talk a little bit about redeployment, which was a big issue for us working in chronic disease when our staff were taken for the pandemic frontline. And then I'm going to finish up with by telling you about a huge transformation program called the Enhanced Community Care Program that is ongoing within the HSE at the moment. Next slide. So on the left here is a traditional diabetes clinic delivered by me in Addenbrooke's when I was over there working in the NHS. I had a white coat still with long sleeves. My hair had not yet turned grey. But the point of this slide is that we bring people to the centre. We bring them up, to the hospital, even though they may not be unwell necessarily. And that's changing. On the right, prior to the pandemic, this is a more modern approach to diabetes care. There is no chart. We use computers now for documenting care. We have a young man here wearing an insulin pump, not obvious from the slide, from the image, but he has a device providing him with insulin continuously, and he's able to bolus when he eats. He's also got in his hand, and the reason for the film crew is that we were demonstrating the development of a more person-centered approach. Diabetes clinic visits, particularly for young adults, are not always a positive experience. We've tried to make them more person-centered by introducing a tool called an agenda setting tool, which I'll show you in a little bit more detail on the next slide. Also point out that my hair has turned grey and I'm bare below the elbows on this. So big change from the NHS. Next slide, Catherine. So the same image, and the next slide this is our agenda setting tool, which is basically, if you can click forward, Catherine, one. So this is asking the young person to tell us what they would like to get out of the visit. So chronic disease management is not all about the doctor or the healthcare professional's agenda, but it's very much about what you want to get out of the visit. Top right, trying to shift that dynamic away from clinic visits being a negative experience. Tell us something that's positive in your life. our young adults have really embraced this and really value being asked about it. We then ask about some diabetes stuff, like how confident are you with carb counting? Have you had any episodes of DKA or hypoglycemia that we might not be aware of? And then here is a DDS2, it's called, or a diabetes distress scale. 2 items, screening for the burden, not of diabetes, but the burden of living with a chronic illness, which again, particularly in the young adult setting, is really quite pervasive. And again, as we've found out from using this tool, can really open a conversation around issues that are not necessarily blood sugar issues. Next slide. So, and then to round off, that's type 1 diabetes, which will remain a hospital condition managed in hospital. But type 2 diabetes, as we speak, is shifting left, to use the Slointecare phrase. And this is me quite recently delivering a community diabetes clinic for people with type 2 diabetes in a beautiful new Tuam Primary Care Centre here in the west of Ireland. Next slide, Catherine, is also then used with the same nurse, Bernie McDonald, delivering care virtually. So the patient has been cropped out of this slide, but Bernie is with the patient in Tuam. I'm in my office in Galway. And I'm highlighting this because we have progressed through the pandemic to deliver care in ways that we might not have imagined previously. And these are appropriate, in my opinion, to chronic disease management, moving closer to the patient and remotely connecting in with the patient. Next slide. So the other thing that has changed in recent years in diabetes care, some of you may have noticed this on Theresa May's arm when she was on our television screens, but this is the Freestyle Libre, or the flash glucose monitoring device, which Diarmuid will probably refer to in his talk, but it's a moving away from the drudgery of blood glucose, monitoring blood glucose by finger pricking. So a sensor disc is worn on the arm, and then this monitor, or even nowadays the patient's smartphone, is used to scan the sensor and get continuous readings of glucose. The arrow is more important to the patient than the number. So this is 6.2 and rising. And this technology is really changing the way that we deliver diabetes care. Next slide. Our clinics now frequently involve screening, or discussing rather, with patients charts like this, with time in range, as it's called, as opposed to A1C, and then, you know, graphs depicting the patient's blood sugar, the equivalent of about 250 blood glucose readings per day multiplied by 14 days. So this is like the Holter monitor of the diabetes world, and it is phenomenal. And being able to do it remotely and checking in with the patient at the same time and interpreting it and learning from them as to why there are ups and downs has been really quite rewarding. Next slide. So the other thing to mention is we type 1 diabetes education, and indeed type 2, is really the cornerstone of management of diabetes. We have a program delivered in Beaumont, in Galway, in Kilkenny, in about 13 hospitals, 6 or 7 hospitals prior to the pandemic, about 13 now, including the Beacon, which is the first private hospital to deliver this program. High quality self-management education delivered pre-pandemic by a nurse and a dietitian to a group of patients living with type 1. But now post-pandemic, Daphne has gone remote, and it's more freely available to patients and to teams like ourselves, busy with all the other issues that we deal with. And when we're estimating that there will be 5 or 6 more centres coming on stream in 2022, so that more than half of the hospitals, of the 30 or so hospitals delivering diabetes care in Ireland, will be delivering this program. Next slide. And this is what's the word? Plum, or this is kind of highlighting my own personal achievement of becoming a Daphne educator during the pandemic. The training, I can tell you, was not straightforward and quite lengthy, but very rewarding. Next slide. So what about, and then just to point out that, as our diabetes centre administrator said to me around the time of the cyber attack, She said, and I remember it as a moment in the pandemic, she said, Sean, this is worse than COVID. And of course, you know, because we have become so dependent on the remote and virtual world for delivering care, we are completely scuppered if Russian cyber criminals take down our health service. I don't need to tell you that, but chronic disease management is virtually impossible when it's delivered remotely. Next slide. What about Retina Screen? I don't know if David Keegan is on the call, but he is responsible for this program, which is without a doubt impacting on vision loss from diabetes in Ireland, because we know from other countries that it reduces the incidence and prevalence of sight-threatening retinopathy, and it is phenomenal. Next slide. Unfortunately, foot screening is not as well organized in Ireland. So on the first column here, you have parameters that indicate quality for a screening program of any type. You should be able to maintain a register, have ring-fenced funding, staff dedicated to the screening, and so on. Retina Screen ticks all of the boxes. Diabetic foot screening ticks almost none. So a concern of ours as a clinical program is to try and get foot screening to where retina screening is and reduce limb loss as well as vision loss from diabetes. Next slide. So in terms of foot care, this picture appeared in the Galway Advertiser during one of the COVID surges, and my heart sank because I knew 3 of the 5 people in the photograph personally because they're podiatrists. Next slide. And because of redeployment of podiatry staff to the pandemic frontline, and I'm not against that, it was deemed necessary by the decision makers at the time, but we lost out on podiatry contacts. So visits to our Merlin Park podiatry clinic tanked. And as a result, next slide, and I can't prove this for certain, but foot ulceration without a doubt would have gone up when these high-risk patients were not being seen for the follow-up care that they needed. So one negative aspect of the pandemic. But on a positive note, we did respond. Yeah, next slide is fine. We did respond as a program to reach out to our staff, our patients, providing guidance on delivering diabetes care during the pandemic. Guidance later on resumption of services, sick day rules for patients. We had regular meetings of our clinical advisory group and joined up with our network of colleagues in the north, which was a very positive thing, sharing our experiences and learning from each other. We advocated to the HSE for return of redeployed staff. We developed online offerings, as I showed you, around diabetes education, and made the CareLink system and other systems more available in our acute hospitals. Next slide. Sick day rules are important, and just to remind you, if you live with type 1 diabetes and you get sick, you need to do these things. Keep yourself well hydrated, check for ketones, monitor more frequently, never ever stop the long-acting insulin, take quick-acting insulin according to your need, and know when to call for help. Next slide. The other aspect of the pandemic that I think affected all of us was this idea of being isolated, not just, sick day rules from the standpoint of the body or the biology, but also of the psychology. And this woman, Rose Stewart, who's a psychologist in Wales, has done some really nice work highlighting this to us. Next slide. Not just our patients, as I say, but our staff. So this figure from Rose Stewart's work shows the first wave immediate mortality from COVID-19, the second wave impact of resource restriction during the spike. Later on, the third wave impact on interrupted care for chronic conditions like I showed you with the podiatrists being redeployed. But what I like about this slide is she refers to what she calls the psychic trauma. And we've all been through it, I think, as caregivers and indeed as patients. Next slide. And one intervention that, if you're not familiar with, I would encourage you to get familiar with is the Schwartz round, which we have the privilege of being involved in piloting it here in Galway. One of 2 sites, the Blackrock Hospice being the other. And we shifted to virtual during the pandemic to try and support each other, reflecting on the stresses involved in delivering COVID care. Next slide. So finally, next slide, I'm going to take you briefly through the Enhanced Community Care Programme. And this is public health, I think, at its best, delivering chronic care. One question is, for a country, who has the chronic disease, in this case diabetes. This is a Euro Diabetes Index, a survey of 30 countries across Europe done in 2014, looking at and scoring them on aspects of good chronic disease management. Ireland, sadly, came 20th out of the 30 nations. What you will notice is that the having a national diabetes registry is a prerequisite, in my opinion, to delivering good chronic disease management. Who has the condition? So 5 of the top 10 countries had a registry and only 1 of the bottom 10. Next slide. So we have been working to try and develop a national diabetes registry in Ireland. Unfortunately, that Sláinte to Care funded project had to be stood down because the public health and the ICT functions were consumed with COVID care. We also have received or benefited from Sláinte to Care funding to develop a national diabetes prevention program and to develop what's called end-to-end or good chronic disease care delivered in the community. Next slide. And this is the Enhanced Community Care Programme, focusing on ICPOP, which is integrated care for older persons, and integrated care for chronic disease, keeping people well in the community, using general practice to screen for foot risk, for example, and to manage stable type 2, to develop ambulatory care hubs, as they're called, which are being put into the community, and funding specialist teams in those hubs, and keeping people away from the top end of the pyramid, which is hospital, outpatient and inpatient care. Next slide. So the funding going into the Enhanced Community Care Programme is phenomenal. Each of these hubs will have a team, a specialist team, delivering care for people with type 2 diabetes, care for patients with heart failure and COPD. And you can see the level of funding and the level of staffing is more than a lot of hospital teams have at the moment. Next slide. I think that's it. Yeah, thanks very much for your time. I'll be happy to take any questions now or perhaps at the end.
Thanks, Sean, very much indeed. I think we probably keep questions to the end, but I mean, the dynamism and the importance of what you're doing is really informative. So thank you so much. Maybe you can ask if Diarmuid is going to take it on from there. I'll leave it with you.
Yeah, thank you. So thank you very much. My name is Diarmuid Smith, and thank you to the RCSI for asking me to speak today. So I'm going to talk a little bit about type 1 diabetes. Next slide, please. So last year was the 100th-year anniversary of the discovery of insulin. And before the discovery of insulin, if you had type 1 diabetes, essentially you died. Patients with type 1 diabetes would have died within a year to 2 of diagnosis from ketoacidosis. And the gentleman on the right was actually a surgeon, Frederick Banting. And he's pictured on the left here with Charles Best, who was a medical student at the time. And Banting actually ligated the common bile duct, and you removed an extract from the common bile duct, which suppressed ketosis, inhibited lipolysis, and was involved in the metabolism of carbohydrates. And he called it inulin at the time. And essentially, the dog in the front is a dog called Marjorie, and Banting removed the pancreas from Marjorie and injected his extract into Marjorie and kept her alive for 70 days. And essentially, when he stopped the extract, Marjorie died. And that was the first discovery of insulin, and it was a miracle at the time. So I think it's really noticeable, and I'm sure Banting would be delighted that we have a surgical group here trying to learn a bit more about diabetes. So I think that's a fantastic initiative from the RCSI. Next slide, please. So type 1 diabetes is common and it's a genetic condition. So patients with type 1 diabetes are born with a genetic predisposition to developing type 1 diabetes. And then something happens, probably a viral trigger that triggers an autoimmune response, and those antibodies attack the beta cell of the pancreas and destroy the beta cell of the pancreas. So type 1 diabetes affects about 23,000 adults in Ireland. And essentially the key point here is that these patients are not producing insulin. They're insulin deficient. So their treatment is either subcutaneous insulin injections or a subcutaneous insulin pump. There's no role for oral hypoglycemic agents per se in the management of these patients. And the key point is that if you don't give them insulin, and if you hold insulin or withhold insulin from them, they're at risk of developing ketoacidosis. Ketoacidosis is a medical emergency. and is associated with death. 1% of patients with diabetic ketoacidosis can die. Next slide, please. So we define diabetic ketoacidosis as a glucose level of greater than 11.1 millimoles with blood ketones of greater than 3 and a pH of less than 7.3. And this is our protocol in Beaumont Hospital of how we manage it. Now, I don't expect you to remember this. This is a medical issue. And obviously, if someone develops ketoacidosis, you'd ask for a medical consult. But there's just a couple of key points. One, ketoacidosis can often present with abdominal pain. So if a patient with type 1 diabetes or type 2 diabetes, because 5% of type 2 patients can develop ketoacidosis, come into casualty with abdominal pain, this could be ketoacidosis and a medical issue. Secondly, if you're on the wards with somebody with type 1 diabetes and they're sick, it is always very useful to measure their blood ketones. Next slide, please. Now, when we have a patient with type 1 diabetes, they're deficient in insulin, as I mentioned. And so what we try and do is mimic what the normal beta cell of the pancreas does. And the beta cell of the pancreas produces a little bit of insulin every minute of the day. And that is called basal insulin. So essentially, if a patient with type 1 diabetes decides to wake up tomorrow and says to himself, I'm not going to eat anything today, they're still producing a little bit of basal background insulin. And that basal insulin sort of suppresses hepatic gluconeogenesis, inhibits lipolysis, and keeps the patient out of trouble. So that basal insulin is extremely important. Then when the patient eats a meal with carbohydrate, then they get a spike in their blood sugar and they get a spike in insulin production in the non-diabetic to match that meal. And we call that bolus insulin secretion. So we have different insulins that are basal insulins and different insulins that are bolus insulins. Next slide, please. So this is a list of names of the basal insulins that are available in Ireland. Now, the older basal insulin is called NPH or Insultard, which is a cloudy insulin given once or twice a day, typically used in pregnancy. The other basal insulins listed are more commonly used. They're clear insulins, and they're given once or twice a day. Now, if they're given once a day, that can be given at any time of the day, either before breakfast, lunch, evening meal, or at bedtime. They're usually given in the evening or bedtime. The levemir insulin is often given twice a day. Next slide, please. Those basal insulins that I showed before typically last for 24 hours. So when you inject them, they last for up to 24 hours. The bolus insulins are listed as here. Now, the oldest bolus insulin that we have is called that rapid or regular or soluble insulin. Now, that's an insulin that you inject about 30 minutes before you eat. It peaks after 2 hours of injection and hangs around for about 5 to 8 hours. The other insulins, the NovoRapid, Humalog, Glulisine, we recommend that they're injected maybe about 15 to 20 minutes before you eat. They peak within about an hour of injection and they last for 4 to 5 hours. And now there's a newer, quicker acting insulin called Fiasp insulin that you inject as you eat. And again, that lasts for about 4 to 5 hours. It gets absorbed a bit more quickly than the NovoRapid insulins. So these bolus insulins are given with meals. Now, we also have pumps, and about 10 to 15% of type 1s are on insulin pump therapy. And this is one of our newer pumps on the right-hand side. Clips onto the belt or sits in a pocket. And there's an infusion kit coming out of it that delivers subcutaneous insulin. So a little needle is inserted subcutaneously, the needle then removed, and you have an infusion site that delivers subcutaneous insulin. Now, the pump delivers the bolus insulin. So when a patient's on a pump, the bolus insulin becomes both the background and the bolus insulin. So the pump delivers a little bit of insulin every couple of minutes, such as NovoRapid. And then when the patient eats a meal, they press a couple of buttons on the pump to deliver the bolus of insulin. So that's an important point to remember. If you have somebody on a pump and the pump blocks or dislodges or gets removed, because there's no longer acting basal insulin on board, the patient can very quickly go into ketoacidosis. So that's a very important point. On the left-hand side, you see this CGM device that Sean has mentioned, which is a continuous glucose monitor. And that can send a signal to the pump or to a phone device that the patient may have, and it can give a real-time glucose reading. Now, these systems are very elaborate, and these CGM devices can detect if the blood glucose levels are starting to go low and can tell the pump to stop delivering insulin before the patient goes hypoglycemic. And when the glucose levels then start to rise, the sensor will tell the pump to redeliver the insulin. Now, an important point with these sensors, which are becoming increasingly common, they use an electrical current in the sensor. So if a patient is going for surgery, you can't use diathermy with the sensor. You need to remove the sensor. If you remove the sensor, the pump will still work, but the sensor would need to be removed, and it also needs to be removed if you're going for an MRI scan, etc. Next slide, please. So these sensors can also be used with multiple daily injections. They don't necessarily need to be used with a pump. This is a continuous glucose monitor that relates to a phone called the Dexcom system. And this Dexcom system can get your phone to alarm if your glucose levels are going too low or too high. They're very useful, and we've seen significant improvements in diabetes control with this technology. This is an intermittent sensor or a Freestyle Libre system. It's intermittent because you just need to activate the sensor with your phone or a handheld device to see the reading. But this technology is becoming increasingly prevalent, and the ADA and the European Diabetes Associations both recommend that they should be offered to all patients with type 1 diabetes. So you'll see patients coming into the hospitals with this technology. Next slide, please. So I'm going to give you some cases about how to manage type 1 diabetes on the surgical wards. And I'm going to show you some of the protocols we use in Beaumont, and most hospitals have their own protocols. But this is a 31-year-old female with 10 years of type 1 diabetes. She's on Lantus 24 units a day. Lantus is our basal background insulin. She's on NovoRapid pre-meals, and she carbohydrate counts. So that means she's adjusting her NovoRapid to carbohydrate. So instead of being on fixed doses of, let's say, NovoRapid 6 units before each meal, we encourage our patients to carbohydrate count. And so a patient might end up on 1 unit to 10 grams of carbohydrate. And if they come into hospital on carbohydrate counting, we'd encourage them to continue to use that skill when they're an inpatient in hospital. She's got reasonable diabetes control with a HbA1c of 7.8%. Ideally, we aim for a target of less than 7%. And she comes in for an elective hernia repair, and her blood glucose is 7.8 on admission. Next slide, please. So this is the protocol we use for our patients with type 1 diabetes. So essentially, the day before their surgery, we give them their usual dose of their basal insulin the night or the day before the operation. The day before the surgery, they're eating properly, so they take their bolus insulin with meals. They fast from midnight. If they go hypoglycemic overnight, they can take some dextrose sweets to bring their glucose level back up to normal, and that doesn't stop them having a general anesthetic. On the day of the surgery, if they take their basal insulin in the morning time, we reduce the dose by 20%. Because they're fasting, they're not eating, so they don't take a bolus insulin dose in the morning time. So they don't take their quick-acting NovoRapid, etc. If they come in with glucose, we then recommend starting them on an intravenous insulin infusion. If they go low during the operation, you treat the hypoglycemia appropriately. And then once the operation is over and they're allowed to eat again, then they take their bolus insulin with the food. And then if they're on their basal insulin at nighttime, they take their basal insulin at night. So this protocol is getting away from the glucose potassium insulin infusion that may have been used in the past in a number of hospitals. In Beaumont, we don't necessarily use that anymore. The day after surgery, if they're eating well, they take their usual doses of insulin. Next slide, please. Now, if they come in on an insulin pump, an insulin pump is a very effective way to manage diabetes around the time of surgery. So we'd actually recommend that they wear their pump during the operation, and that can manage their diabetes control appropriately. However, again, if they come in on the pump and their glucose levels are high, they take a correction bolus through the pump, and the patient should be educated on being able to do that. So they might take a bolus of quick-acting insulin to lower the glucose levels. That should bring the glucose levels down within a couple of hours. But if it doesn't, then we'd recommend stopping the pump, switching the patient to an intravenous insulin infusion, and I'll explain that in a slide or two. Store the pump safely for the patient, and then when the patient's well after surgery, they can restart their pump therapy. Next slide, please. So the same case comes in for a hernia repair, but our glucose level is 22. The first thing you do in this setting for blood ketones. Next slide, sorry. And if our ketone is positive, then you'd be worried that the person has diabetic ketoacidosis. So if our ketones are positive, then she could have diabetic ketoacidosis, particularly if the blood ketones are greater than 1.0 millimoles, and we ketones, you'd cancel the surgery, consult endocrinology, medical emergency, IV fluids, IV insulin infusion. If our ketones are negative, the surgery could still go ahead on an intravenous insulin infusion. Next slide, please. Variable rate insulin infusion, and this is the protocol we use, where we get 50 mils of Actrapid with 50 mils of normal saline. We put it in a syringe driver and we infuse it intravenously. We typically start off with 6 units per hour. We check the glucose every 1 to 2 hours. We pump the glucose level down using this scale. Essentially, when the glucose level gets to less than 10 millimoles per liter, we add in a bag of 5% dextrose at about 100 mils per hour to maintain normal glycemia, because if you leave them on the IV insulin, dextrose are likely to go hypoglycemic. The IV insulin then stopped, risk of ketosis can arise. So we use the IV infusion initially on its own to pump the glucose down, then start some dextrose to maintain normal glycemia and bring the patient through their operation. Next slide, please. Another case of a 68-year-old man who comes in, type 1 diabetes. He's on the standard basal bolus regime of the Lantus, which is the basal insulin once a day, and the bolus insulin with meals. But he's got a ruptured aortic aneurysm. So he's in the middle of the night, emergency surgery, glucose level is high. Next slide, please. Again, if glucose level is high, check for ketones. Ketones positive, then he needs to be treated as a DKA. If his ketones are negative, but he's emergency surgery, then we would go for the variable rate insulin infusion. We'd start them on that intravenous insulin infusion. We would leave them on their basal insulin. We'd continue to prescribe their basal insulin because that makes it easier for us to transition them off the IV insulin back to subcutaneous insulin in the future. If they were on a pump, we'd stop the pump, leave them on their intravenous insulin, and store the pump safely for the patient so that he can restart it when he's well. Next slide, please. Another case, and this is probably one of the commonest cases you'll see. So this is a 36-year-old female with type 1 diabetes for 12 years. Now she's on Novorapid, her bolus insulin, 1 unit to 10 grams, and she's on a twice daily basal insulin, 12 units in the morning and 14 units in the evening of Levemir. She's had a laparoscopic cholecystectomy, and on day 3, she started to vomit and not eating, and her glucose level is 4.2, and the ward nurse says, should we hold the insulin? And this is really one of the key points of this lecture tonight. In type 1 diabetes, you don't hold, you do not stop the basal insulin treatment. So in this case, if the ward nurse asks you, should we hold the insulin, you continue to give the basal insulin. Now, you may need to reduce the dose maybe slightly by a couple of units because the glucose level is 4.2 or if she was hypoglycemic. but you continue to give the basal insulin. So you never, ever, ever, ever stop the basal insulin. Next slide, please. Because she's not eating pre-meal NovoRapid, her glucose level is only 4. So you can hold the pre-meal NovoRapid. We would recommend using supplements of NovoRapid, and I'll explain that in a second. You need to monitor the glucose carefully. Levels start to rise, consider checking for send the consult to endocrinology. Next slide, please. So this is what we use now instead of really the traditional sliding scale. To me, when I'm trainee, we used to use a lot of the 2-hour sliding scales using ActRapid. Now remember, ActRapid took, so in the old days, we used to have a scale where maybe a patient with diabetes, their glucose level was 18, and they'd be charged for 6 units of ActRapid. And then 2 hours later, the glucose level would be 18 because the ActRapid hasn't kicked in. The nurse would give another 6 units of ActRapid. Then 2 hours later, the patient would be hypoglycemic because they've now had 12. So they become hypoglycemic. They're then given rescue therapy to treat the hypoglycemia. The glucose jumps back up to 18. They're given another 6 units of ActRapid. 2 hours after that, it's still 18, given another 6 units of ActRapid. So the 2-hour sliding scale ActRapid should not be used. It's bad practice. Instead, we use these supplementary scales. So essentially, this is trying to take the edge off hyperglycemia for a patient. We recommend that you chart their usual bolus insulin. So if they're on NovoRapid, you use NovoRapid. It's given at pre-time to let the insulin take a little bit of time to work. And we write up a scale like this. We're aiming for glucose levels millimoles, but we could live with 4 to 12 millimoles. So they, with this supplementary scale, they take their usual dose of bolus insulin, and if they're high, then they take an extra dose of NovoRapid with. Again, if somebody is not eating, let's say you're not giving them their usual bolus NovoRapid, but their glucose level was 12.4, you'd give them 2 units of NovoRapid. NovoRapid to correct a glucose level that's slightly high. Next slide, please. So again, with this case, and this just illustrates it a bit more. Again, the same patient on laparoscopic cholecystectomy starts vomiting, glucose level of 16. The ward nurse asks you, should we give the insulin? So again, next slide. Again, your approach would be to check for ketones. If positive, you treat them as a DKA. You give the basal insulin. You then can go to your supplementary scale and give a correction dose to try and lower that glucose level. If the ketones are initially negative, but then start to rise, then you're in trouble and you need to intravenous insulin and ask for a consult to endocrinology. Next slide, please. There's some special circumstances for type 1 diabetes, and if patients are on TPN with type 1 diabetes, I'd recommend an intravenous insulin infusion. That's often the best way to manage them. If they're on NG feeding, in Beaumont, we certainly recommend the use of BD, basal insulin, and often we use regular bolus insulins to match and to accommodate the 2 or 4 hours that they're broken off the NG feed. Steroids will of course increase blood glucose levels, so standard insulin doses need to be increased across the board by maybe 20 to 30%. And BD mixed insulin is a bit of a challenge, but I'll leave that to Dr. Bogdanet, who's going to talk about that in her presentation. Next slide, please. So this is an important slide, and I actually saw this week on one of our urology wards. And essentially, this patient was on 8 units of Lantus. But the team, or one of the NCHDs, looked at the chart and looked at an old outpatient note where the patient was prescribed 8U. So the doctor had written in the clinical letter 8U Lantus BD. Now the doctor then transcribed that 8U as 80 and wrote milligrams instead of units. So the patient got 10 times their Lantus dose and spent a whole night hypoglycemic on intravenous dextrose to try and keep his glucose levels in normal. Next slide, please. So a key point is insulin is a high-risk drug. And when you're prescribing insulin, you need to be careful about the prescription. Never prescribe U or IU. If you're prescribing insulin, you have to write units. Next slide, please. I'll finish up there just by sort of saying again to emphasize type 1 diabetes patients are insulin deficient. Don't stop the basal insulin. Be careful when you're prescribing insulin. It's a high-risk drug. Use your hospital guidelines and always ask your helpful endocrinologist for assistance if you run into problems. Thank you very much. Thanks
a lot, Diarmuid. And just a very comprehensive overview and very case-based, which I hope will really kind of resonate with the surgeons and the trainees on the call. So just in the final part of the webinar then, I'm going to hand over to Dr. Delia Bogdanet, who is an ICAT fellow, the Irish Clinical Academic Training Programme. So Delia is an endocrine SPR based here in Galway and is completing her PhD with Professor Fidelma Dunn, working in the area of gestational diabetes. But this evening, Delia is going to take us through an overview of issues relating to type 2 diabetes, which of course, as you know, is far commoner than type 1 diabetes in the population at large. Delia, thank you.
So again, good evening. Thank you for your patience. My name is Delia Bogdanet, and today we're going to talk about the perioperative management of adults with type 2 diabetes. Poor diabetes control is associated with poor surgical outcomes. According to a study published in Diabetes Care by Frisch et al., poor glycemic control surgery is associated with a 1.5 increase in mortality, 2.5 increase in post-op respiratory infections, twofold increase in surgical site infections, 3 times increase in urinary tract infections, and twice increase in myocardial infarction and AKI. This is a summary of the steps involved in the pre-op assessment of diabetic patients. The first step is to assess diabetic control with an HbA1c in the last 3 months and/or of blood glucose level. One needs to assess potential diabetes-related complications such as heart disease, kidney disease, or gastroparesis. It is important to retrieve an accurate medication list and review the anti-diabetic medication, oral hypoglycemic agents and/or insulin, their doses, and their timing. During admission, the blood glucose targets should be below 10 millimoles per liter. An additional recommendation include to avoid fasting for long periods of time, and ideally, the surgery should be scheduled for the morning. According to the Association of Anaesthetists of Great Britain and Ireland guidelines for the pre-op assessment of patients with type 2 diabetes, information on the duration, type of diabetes, current treatment, and complications should be made available at the time of referral for surgery. Glycemic control should also be checked at the time of referral for surgery. Ideally, the HbA1c level should be less than 69 millimoles per mole, or 8.5%, in the previous 3 months. If not, elective surgery should be delayed if possible while control is improved. Early pre-op assessments should be arranged with a diabetic nurse specialist, and tests should be ordered to assess comorbidities, including urea electrolytes and ECG. A random blood glucose measurement is not indicated. Patients with poorly controlled diabetes at the time of surgery will need close monitoring and may need to start a variable rate intravenous insulin infusion. The Association of Anaesthetists of Great Britain and Ireland also advised that when planning surgery, it is very important to minimize the fasting period ensure normal glycemia, aiming for a blood glucose of 6 to 10, and minimize disruption to the patient's usual routine. Ideally, the patient should be booked first on the operating list to minimize the period of fastings. Patients should be provided with written instructions from the pre-op assessment team about management of their diabetes medication on the day of surgery, the management of hypo or hyperglycemia in the perioperative period, and the likely effect of surgery on their diabetes control. Patients should be advised to carry a form of glucose that they can take in case of symptoms of hypoglycemia that will not cause the surgery to be cancelled. In terms of medications, in the following slides, we will remind ourselves of the drug classes of oral hypoglycemic agents used in the treatment of type 2 diabetes. Highlighted in bold are the most common classes used in the management of type 2 diabetes, and in our discussion we will focus on those. First, we have alpha-glucosinase inhibitors, an example of which is acarbose, which act by delaying carbohydrate absorption from the intestine. Aniline analogs act by decreasing glucagon secretion, slow gastric emptying, and increase satiety. Biguanides, just as metformin, decrease hepatic glucose production and increase glucose uptake in the muscle. Bile acid sequestrants also decrease hepatic glucose production and increase incretin levels. Dipeptidyl peptidase 4 inhibitors, such as linagliptin or sitagliptin, act by increasing glucose-dependent insulin secretion and decrease glucagon secretion. Dopamine agonists, such as bromkriptin, activate dopaminergic receptors, and glinidin increase insulin secretion. To continue the list, glucagon-like peptide receptor agonists, such as dulaglutide or liraglutide, increase glucose-dependent insulin secretion, decrease glucagon secretion, slow gastric emptying, and increase satiety. Sodium glucose cotransporter 2 inhibitors, such as dapagliflozin or empagliflozin, increase urinary excretion of glucose. Sulfonylureas, such as glycoside, increase insulin secretion, and thiazidines, such as pioglitazone, increase glucose uptake in muscle and fat and decrease hepatic glucose production. So in terms of oral medication, on the day before surgery, all oral medications should be taken as normal. However, on the day of surgery, sulfonylureas, SGLT2 inhibitors, and GLP-1 receptor agonists should be omitted. Note, if on variable rate intravenous insulin infusion, stop oral hypoglycemic agents until eating and drinking normally. In the post-op period, metformin should be held if the patient is NPO or on enteral nutrition or if the eGFR is below 30. Sulfonylureas and thiazidines should be restarted if there's normal food intake. DPP-4 inhibitors should be restarted with normal food intake, but there's a special caution here in case the patient undergoes pancreatic surgery or has pancreatitis, and expert advice should be sought. SGLT2 inhibitors should be held until the patient has made a full recovery and until the patient has resumed normal food and water intake. Special caution here, as the SGLT2 inhibitors are associated with the risk of euglycemic ketoacidosis. GLP-1 receptor agonists also need to be held until fully recovered, and a special caution is raised here in patients who undergo pancreatic surgery, and expert advice should be sought. As I mentioned, SGLT2 inhibitors are associated with the risk of euglycemic ketoacidosis. Ketoacidosis is defined by increased annual gap metabolic acidosis with a pH less than 7.3, bicarbonate under 15, and an adient gap over 12, ketonemia or ketonuria, and a blood sugar below 14 millimoles per liter. It has a prevalence of 0.25%, and it is advised that if patients on SGLT2 inhibitors have a blood sugar above 10 and under 14 and are clinically unwell, ketones should be checked. Type 2 diabetes patients on once daily or twice daily basal insulin. The day before surgery, If the insulin is taken in the morning, the dose should be the same. If the insulin is taken in the evening, we should reduce the dose by 20%. Special caution for patients on very high doses of insulin and patients at high risk of hypoglycemia. Seek specialist advice. On the day of surgery, reduce the morning dose of the basal insulin by 20%. If the blood sugars are above 12, start variable rate intravenous insulin infusion, and the blood sugars are under 4, start hypoglycemia protocol. Give the evening dose as normal if the patient is eating. The day after the surgery, if there is normal food intake, give the normal doses. If the patient is unwell or not eating, give the basal insulin and seek expert advice. Patients with type 2 diabetes on BD mixed insulin. The day before surgery, the morning dose should be taken as normal and the evening dose decreased by 30%. Again, a special caution in patients on very high doses of insulin and in patients at risk of hypoglycemia. The day of the surgery, the morning dose should be reduced by 50%. If the blood sugars are over 12, the variable rate intravenous insulin infusion should be started, and if the blood sugars are under 4, hypoglycemia protocol should be started. If patient is eating, reduce the evening dose by 30%, and if the patient is not eating, reduce the evening dose by 50%. The day after surgery, normal doses should be taken if there is normal food intake, but if the patient is unwell, seek expert advice. Intraoperative care and monitoring. The blood sugar aim intraoperatively should be 6 to 10 millimoles per liter. The blood sugar should be checked before the induction of anesthesia and monitored regularly during the procedure. If the blood sugar is over 12 and insulin has been omitted, immediately check capillary blood ketones. If the capillary blood ketones are over 3 or there is significant ketonuria, the patient should be treated as having DKA. If it's not DKA, the high blood sugar should be corrected using subcutaneous insulin or by altering the rate of the variable rate insulin infusion if in use. If 2 subcutaneous insulin do not work, a variable rate insulin infusion should be started. Subcutaneous rapid-acting insulin should be given up to a maximum of 6 units. The blood sugar should be checked hourly and the second dose considered only after 2 hours. In case the patient is undergoing emergency surgery, ascertain timing and amount of the last dose of insulin or oral hypoglycemics. Check the blood sugars preoperatively and start continuous insulin infusion with blood sugar being checked hourly. If the patient is undergoing elective surgery, follow the pre-op oral hypoglycemic and/or insulin guidelines for the day before and the day of surgery and check the blood sugars preoperatively. If the patient is critically ill with poorly controlled blood sugars at home, if you anticipate large hemodynamic changes or large volume and temperature shifts, or if the surgical time is over 4 hours, then start the patient on an IV insulin infusion with hourly blood sugar checks. If not, then we can continue with subcutaneous insulin doses, check the blood sugars every 2 hours, and treat if the blood sugars are above 10. In case the blood sugars are between 4 and 6 millimoles per liter, insulin should be stopped and 50 ml glucose 20% should be given. If the blood sugars are under 4, insulin should be stopped and 100 ml glucose 20% should be given. Check the blood sugars every 15 minutes until the blood sugars are between 4 and 6. Once the blood sugars are over 10, resume the subcut insulin using a more sensitive scale or restart the infusion at half the previous rate. In terms of fluid management, Hartmann solution is safe to administer to patients with diabetes. Glucose 5% should be avoided. And remember that the use of glucose 5% and 0.18% saline can be associated with hyponatremia. Variable rate insulin infusion is preferred in patients who will miss more than 1 meal, patients with poorly controlled diabetes as defined with an HbA1c over 69 millimoles per mole, and most patients with diabetes requiring emergency surgery. When transferring from a variable rate insulin infusion back to oral treatments or subcutaneous insulin, one needs to know that oral hypoglycemic agents should be recommended at a pre-op dose once the patient is ready to eat and drink. Withholding or reduction in sulfonylureas may be required if the food intake is likely to be reduced. Metformin should only be restarted if the eGFR is above 50. Conversion to subcut insulin should commence once the patient is able to eat and drink. And if the patient has an infection or altered food intake or any other complication post-op, the pre-surgical treatment should be restarted but may require adjustment of doses. In terms of safety of insulin, the errors in insulin prescribing are common. Insulin has been identified as one of the top 5 high-risk medications in the inpatient environment. Death or severe harm as a result of maladministration of insulin, including failure to use the specific insulin syringe, is a never event. The wide range of preparations and devices available for insulin administration increase the potential for error. And 1/3 of all inpatient medical errors leading to death within 48 hours post-op involve insulin administration. Thank you for your attention, and I welcome any questions you might have.
Thanks, Delia, and thanks, Diarmuid. Everything you needed to know about diabetes, folks, in just over 50 minutes. So, Ronan, back to yourself.
Well, yes, thank you. I now know that if I have to treat a diabetic, I'm going to ask for help immediately they come in the door, because the complexity of the number of medications that is now available is just extraordinary, particularly for the type 2 diabetic.
It's phenomenal. Delia, you're still on screen share. Can you maybe just mute your device? We're still seeing your screen. Yeah, Ronan, I agree. Even looking at Delia's slide there of the oral agents, we have about 20, when I last looked, about 20 different formulations of insulin, and we do not need that many. But I was flabbergasted at the number of oral agents, many of which are available in the US. And I think, you know, without being too cynical about it, as well as a global pandemic, type 2 diabetes is also a global marketplace. And if you get a tiny bit of that market, you're made. And that's why we have so many insulins and so many, you know, oral agents, and why we have, I think when I last looked, about 6 different angiotensin receptor blockers. You know, it's just, it is partly driven by the market, and that makes for errors, you know, particularly in the insulin world.
Well, this is what immediately came across to me, because I mean, it was so much simpler when you had biguanides and sulfonylureas, and you actually knew how to deal with them. But I mean, I don't even think a diabetic specialist could be able to manage the nuances of some.
I agree. Diarmuid, would you agree?
Oh yeah, it's become much more complicated. I have to say, Ronan, though, that the new medications we have are a huge improvement, particularly on the sulfonylureas. Like the sulfonylureas, I suppose, in the past were a medication that gained weight, caused people to gain weight, caused hypoglycemia. Some of our newer medications, you know, don't cause hypoglycemia and help people lose weight. So certainly in the outpatient setting, there's huge advances in treatment. But in the inpatient setting, for the non-specialists, yes, it's much more complicated.
And you know, just as an editorial comment, when I was in the NHS, the thiazolidinediones were introduced to the NHS, and they had this designation in East Anglia of green drugs which were prescribable by anybody, red drugs which were only prescribed by specialists, so cancer and you know, chemotherapy. But then they had an amber category, and the thiazolidinediones were put in there, and the idea was that primary care practitioners could prescribe them, but in consultation with the specialist. And I thought that was one of the smartest things, and I wish we had that in Ireland, because what it does is it actually creates that dialogue, that really important discussion around chronic disease management with the GPs, you know. And I think that, yeah, several of these drugs could be designated amber in that world.
It does strike me, though, that there's a role here for artificial intelligence to be supportive. I mean, all of these protocols are wonderful and absolutely needed, but once you suddenly find that these have to be translated into a prescription, then, as you've shown, Diarmuid, there is really the opportunity for a disaster.
But I suppose, Ronan, I know sometimes the medication list looks scary, but the basic premise of insulin is that don't be too scared of prescribing insulin. So essentially, the key thing we see is for us as endocrinologists, there's no greater disaster for a patient developing ketoacidosis when they're an inpatient. So in other words, they've come into hospital with a normal glucose, they're looking after diabetes well, acidosis as an inpatient. And usually that's due to medical mismanagement. And often it's that situation of a diabetic patient who's not eating or vomiting. And the question is, from the nurse to the doctor, should we give the insulin? And I suppose one of our key points that myself, Delia, and Sean wanted to get across was the basal insulins. Yes, you keep giving them the basal insulin. And if their blood sugar is high, don't be afraid to give them a correction dose of a quicker acting insulin, the bolus insulin, and ask for help.
Yeah.
But if a nurse is saying to you, I'm not going to give this background insulin to a patient with diabetes, the doctor needs to turn around and say, no, hang on, you do that. Give the basal insulin. That's a key, key message.
From Adrian Ireland, I would appeal for a national guideline adopted in all units. So NCHDs bring their knowledge with them instead of getting confused regarding different practices in different units. I think that's a very sensible comment.
Yeah. Would it were that easy? I know Dick Firth, both Diarmuid and I have been in the National Clinical Program Lead position. Dick was the first of our national leads, and I know he tried to implement some guidance, Diarmuid, around this. And it's very challenging, across the country with the changing of the guard every 3 to 6 months. Perhaps I'm making excuses, but it is a challenge in a system that is not easily where our computer systems, our Q pulses and the like, don't always talk to each other. The second point that Adrian makes, I think we have nailed our colours to the millimole per mole mast in Ireland. A1C measured or reported rather as percentage is something that the Americans have held on to, but we have in Europe moved to millimoles per mole.
And can I ask you all about the role of enhanced recovery programs? And you'll be familiar with these, whereby fasting to liquids is not required, and that includes carbohydrate liquids up to 2 hours preoperatively. How does that impact with somebody coming in for scheduled surgery?
That's to be honest, Ronan, that's where they're allowed to have liquids just up to the time of surgery?
Up to 2 hours preoperative, clear liquids, non-fatty, but it can contain carbohydrates, and that would be part of our enhanced recovery programs for many operations, including, for example, bowel surgery and things like that.
Yeah, so a lot of our patients, as we mentioned, would be skilled in carbohydrate counting. So if they're, let's say, taking a carbohydrate load that's got 20 carbohydrates, a lot of our patients with type 1 diabetes take 1 unit to 10 grams. So if they're having a liquid which contains carbohydrates, they could take rapid with that drink. That would still work very well. Now, if you don't have someone who's skilled in carbohydrate, that makes it a bit more tricky. So in that patient, I suppose what we'd sort of say is if their glucose level was 12 and they're about to have a drink, we would use that supplementary scale as like a correction dose just to get them down before the operation. In the type 2 patient, if you're on tablets and the level is 12, you can't take an extra tablet and get your blood sugar down. That's where you scale in that setting just to correct significant hyperglycemia to get you ready for the operation, or potentially to switch you over to an IV.
Can I ask, how close are we to understanding type 2 diabetes so that we will be able to get some hormonal answer to it? I mean, the fact that just doing a metabolic surgery within 24 hours changes the whole landscape is extraordinary.
It is extraordinary. I agree, and I think the work that you know, Helen Heenahan and Carl LaRue and people are doing, it's fascinating, and it's clearly a lot more. There's a lot more going on than just the weight loss, you know, and this entero-insular, you know, this gut-brain pancreas kind of axis. I think we're only beginning to properly understand it. You know, satiety, appetite regulation, all of these things. So I think, you know, the term in remission is being used now. It came obviously from the cancer world, but, you know, we have the ability to have patients with type 2 diabetes who undergo low calorie liquid diet or bariatric, you know, or metabolic surgery, essentially return to normal glycemia. But we are cautious and careful about saying that their diabetes has gone away. I really like the term in remission. It's used as well in the diabetic foot when a person has had an ulcer. It's reminding the patient that they may not be out the gap, you know, and that with time their beta cells, their insulin resistance, you know, may play up again and they return to having overt diabetes.
Of course, we're going to find the Helicobacter equivalent that's going to answer all of this.
I mean, the amazing thing for me, and I'm at it about the same length of time as yourself, is that we haven't made more progress, Ronan, in type 1. I thought, you know, 10 or 15 years ago, if you had asked me, I would have said there was a race on between immunotherapy or sort of immune, you know, research and technology. And now at this point in 2020, 2022, you know, I could say the technology is streets ahead of the immunology. You know, for a condition that is autoimmune, you know, compared to other autoimmune conditions where rituximab and these drugs have revolutionized management of, you know, rheumatoid disease and inflammatory bowel disease and so on, we've had no success, zero. Diarmuid, would you agree?
Just before Dermot registers and replies, last question for you all. Where is the role of islet cell transplantation?
Yeah, I mean, Diarmuid is probably closest to that. Did you want to take that one, Diarmuid?
So essentially, as you know, pancreas transplantation. And typically pancreas, you have renal transplantation. So you get a thing called a simultaneous pancreas kidney transplant. And we have the National Transplant Center Hospital. And now that's really reserved for patients who are on dialysis going for the kidney. And there's still a role for that. Cell transplantation is different technique. That's essentially where you remove the pancreas. You take a cadaveric pancreas, you put it in a chamber called the Riccardi chamber. You chew it up, you suck out the islets, and with a syringe, important circulation. And really, Ronan, the role of that was for severe recurrent hypoglycemia because islet cell transplantation didn't know diabetes. After about 5 years, only about 50% will be insulin independent. It doesn't necessarily get you off insulin. Dramatic effect in reducing severe hypoglycemia. A lot of patients. But as Sean has said, proves so much now with these sensing technologies that usually sorts out most hypoglycemia problems for most patients. So now islet cell is maybe happening more for a patient who's transplant on immunosuppressants, and then the islets are added in to try and improve the diabetes control off insulin, great. So its indication has sort of changed, but its primary indication, which was severe recurrent hypoglycemia, has certainly dropped because the technology is so good.
Well, can I thank all three of you for what's been a fascinating and most stimulating evening. I think all of us who've listened in have learned a lot. and I think I'm sure that the technology is going to improve even more, so that perhaps we don't need quite the same protocol-driven management, which is perioperatively, that it will be managed by sophisticated monitoring and a pump that is programmed appropriately. But there you are. We watch this space. And
thanks very much for having us,
Diarmuid and Delia, thank you all very much.
Thank you. Thank you all.
Take care. Have a good evening.
Thank you to all who have joined us.
Thank you.